Unless we started already, right? Okay, so this must be it. Log on to your
I hate how fast you switch between your screens. I still like minimize and re-click and. I can remember my password. I tried to practice this morning because my computer automatically. Finished it this morning, so. There's nobody else here.
I was gonna say, can I ask? Okay, yeah, there's no reason even ask. So okay.
I really hope it stays like this, honestly.
That nobody
Yeah,
else
that no one
comes
else
to it.
comes
Yeah.
on.
Just trying to figure out how to.
What's up,
Hey,
man?
what's up? How are you?
Good, how are you?
Press Alt to show her. So worst
What if
case.
you go, click on the
Okay,
screen?
yeah.
Can we go to the Zoom? No, yeah, I don't know.
Try to look it up. if
Dude,
you
I
want.
just,
No,
it does not.
so worst case then, we just won't know until you like
That's fine.
exit it at the end, and then you can see if anybody
Okay.
posted anything. Or if you had an issue, like let's say you move through and you want to go to it, you can just exit and then
Okay.
wherever you're at, just hit this
Sure.
again, and then you can go back right back
Okay.
to where you're at.
Okay.
That sounds good.
Sounds good.
Okay. You're ready.
Noreen, can you hear me? Noreen? Oh, she did? Okay, great. All right, I'm just gonna get started then. Last time people didn't get to see, like, hear me until like, I don't know, a quarter of my presentation was left, so. Okay, so my topic today is just management of the severely burned patient in the ICU. Just kind of quick roadmap of what we're going to be talking about. So just in general, the epidemiology, like who burns affect and why should we care, the different types of burns. We're going to kind of briefly touch on like the ED management and like the overview of the initial management, because a lot of that kind of plays into what we care about as intensivists in the ICU. And then we're going to dive into kind of some of the deeper details of the management, such as burn depth, estimating the extent of the injury, talking about inhalation injury, and then fluid resuscitation. And then we'll end on kind of just post-burn care. So just kind of dealing with the wounds, dealing with kind of the aftermath, and then disposition for these patients. So why do we care about burns? So burns are the leading cause of accidental injury and death in the US and worldwide. About 1 million people a year seek care for burns. Majority are fine and benign and can just go home and don't require any hospitalization. But those that are severe, classified as severe, which we'll talk about the definition, have significant morbidity and mortality. This is related to, as we'll kind of discuss further on, just in general, there's complex metabolic changes that occur with burn patients that affect nearly every organ system. And the management is a long-term process. We often think about like just the ED or the ICU and then transfer the patient. But for the patients, like physiology goes back to normal, can be like upwards of several years. Largely the outcomes depend on where you happen to be when you get burned. So are you in a resource-rich area? How well is your triage, stabilization, and transfer / how prompt it is? And then the worst outcomes tend to be those with extremes of age. So young children or the elderly, they often have thin skin, which leads to deeper, more severe burns. And then those in resource limited areas like combat or mass casualties. So we'll briefly touch on the different types of burns. The focus of my presentation is going to be on thermal injury, just because it's the most common. But there's also electrical injury. This is, electrical energy that's just transformed into heat as the current passes through the body. It largely depends on like how you got involved or came into contact with the current, the resistance of the current flow in the tissues, and then the duration of the current flow. For chemical injury, basically the injury is just due to a large variety of caustic reactions that result in changes in pH, disruption of the cellular membrane, and can cause direct toxic effects. And again, the extent of the injury is largely determined by the type of agent that you came into contact with, and then your duration of the exposure. Radiation is the final type of burn that we're not going to spend much time on. This is my excerpt for it. But the most common is sunburn, which we don't really do anything about. But the other thing that we kind of don't think about too often is therapeutic in like cancer patients. So often, we're giving radiation for some sort of therapeutic reason. And you can get deep tissue burns. It's never really external, like your skin that you're seeing, it's deeper in. And then type of injury relates to the dose, the time of exposure, and then the type of particle that's being used. So now we're going to kind of transition to kind of overview of the initial management of these patients. Before we do that, though, I just want to kind of define what a severe burn is. It's not kind of subjective. There's actually like definition for it. So it's any burn, regardless of your total body surface area, that is accompanied by a major trauma or associated with inhalation injury, which we'll define later. Any chemical burn, any high voltage electrical burn, including like a lightning strike. Greater than 20% total body surface area burned, and just like in case I forget to say this, when I talk about like burns and the total body surface area, this is excluding superficial burns, just so you guys know. And then anybody in the extremes of age, so young children and older adults, as I mentioned earlier, have thinner skin, tend to have deeper, more severe burns. So they can have less than 20% total body surface area, but still be considered a severe burn. So it's interesting because I didn't realize that there is a decent percentage of patients with burns that actually have concomitant traumatic injury. And it makes sense, right? Like a lot of these house fire burns, there's falling debris, they're in a car accident or something. So up to 6% of patients with burns present also with some sort of trauma. Primarily it's a chest or abdominal injury, but inhalation injury also counts as considered like a trauma or a marker of severe burn. So every time a burn patient comes in, and this is again like that kind of ED, initial resuscitation area, you're going to do your primary survey and you're going to do your ATLS algorithm. And essentially you're going to focus on your ABCs up front, right? So any signs of respiratory depression, are they able to maintain their airway? Just they have signs of an inhalation injury, or are they unstable? You should at this point also be getting like IV access and doing removing all the patient's clothing, but just be mindful that when you're doing that, removing clothing and jewelry, that it can be really hot and then you get burned and now you're a patient too. So be mindful. The secondary survey that you're going to do for this patient is now look for your signs of trauma. And this is where you're hopefully going to at least gather some sort of understanding of the history of their circumstances that brought the patient in. Not only is it helpful like to understand, you know, are there more victims coming and things like that, but knowing what material was burned, does it put them at risk at cyanide toxicity? Was it an open or an enclosed fire that occurred? And then was there an explosion that was heard? Was there, that could suggest either like a blast injury or further trauma? Was there falling debris that was going on? You're kind of doing that, and at the same time, then you want to dive into some of the more detailed approach of actually burn resuscitation. And that is first to identify your burn depth, your extent of injury, calculate your resuscitation, and then coordinate transfer if you're not a burn center. And we're kind of going to dive into details on all of these. So to figure out who to transfer, really the simplest thing you can kind of remember is if it's like really severe, you're intubating the patient, transfer them. Any signs of any airway compromise, transfer them. If you have more than 10% total body surface area, again, excluding any superficial burn. And then burns that involve important things like your face, your hands are important, your joints are important. And then the other thing to think about is maybe patients who don't necessarily meet this criteria, but like a child or an elderly person who maybe has comorbidities that make resuscitation then a little bit more difficult. And then any patient that also has a burn with a significant trauma. So now we're going to kind of focus on these details that we talked about. So burn depth is the first one. We're going to talk about the different classification systems of burn depth. So why do we care about the depth of the burn? Like who cares if it's a 1st degree burn or a 3rd degree burn, which is what was formerly referred to as. It's because it largely affects how you're treating these patients, okay? It contributes to the extent of the burn, how we're estimating the extent, and then the overall healing potential and morbidity and mortality for the patient. It's important to remember that our burns are not homogeneous and that we have to constantly frequently reassess these patients because the burns develop over minutes to hours. So what it could initially be a superficial partial thickness might over several hours develop into either a deep or a full thickness burn. And then you might have to change your management because of that. So we kind of got away from the whole like 1st degree, second degree burns and have moved into our classification system of superficial, partial thickness, and full thickness. We'll briefly kind of touch on these because it's not really that important for you guys to take away from this presentation. But superficial burn, think of a sunburn. It's flat, it's red, it's very painful, it's dry, you don't have blisters, and generally healing occurs spontaneously without any intervention in about less than a week. Then you have your partial thickness burns. You have either a superficial or a deep partial thickness. And when it comes to this, the kind of difference between the two is one, pain, and then two, really the healing and what is damaged. So with the superficial partial thickness, you generally blister within about the first 24 hours, and it's this painful red, weeping, kind of beefy red appearance, and heals within about a week to 3 weeks. The deep partial thickness, honestly, is very difficult for especially a non-experienced person to differentiate from a full thickness burn. So when in doubt, you should always assume that your deep partial is a full thickness. But essentially, in addition to damaging both the partial thickness, damage the epidermis and parts of the dermis, the thing is the deep partial involves like the follicle and the glandular structures. They almost always blister, and then this deep partial generally are not painful unless you're poking or touching it, and they're non-blanching. These scar and tend to heal with a longer duration of over 2 to 9 weeks. Full thickness is the worst. It's also like the 4th degree burn. And this involves all layers, including the subcutaneous tissue. It's painless, and it has this like leather-like appearance that can be kind of any color. It can be white, it can be gray, it can be dark, depending on where you are and how far out you are from your burn. Blisters never happen with this, and it's non-blanching. You'll often see an eschar that's covering the burn itself, and that's just like the denatured dermis and tissues or and cell structures like underneath. But it's important to be mindful that these eschars can compromise blood flow and lead to ischemia or ventilation issues, and may necessitate surgical intervention like an escherotomy, which we'll kind of talk about. Generally, when an eschar is present, you'll have severe scarring, often deformities, contractures, and can get like compartment syndrome. And spontaneous healing with an eschar or a full thickness burn is impossible without wound closure and grafting. This chart, for anyone that's visual, kind of just summarizes what I said, but goes through the different types of burns and then their duration and how to differentiate. So now we're going to talk, now that we talked about the different types of burn depth, we can talk about how to estimate the extent of the injury. So once we know, okay, we have X amount of burns, now we have to give like a number to it to then determine our fluid resuscitation. So that's why estimating the extent is really important, and knowing burn depth, because a superficial burn does not contribute to your overall management of the patient. There's multiple different modalities to do. The little, I didn't know it's called the Lund-Broder chart, is the little people at the bottom. That's the most accurate. But you can also do your rules of 9s and then the palm method. And it's important to remember when we're doing the palm method, it is not your palm, it is the patient's palm. So if you have like a little baby, it's the little baby's palm, excluding all their fingers, and that counts as about 1%. Let's see. Okay, so it turns out we're really bad at assessing the extent of burn injury. There was a study that looked at how accurate we are at like estimating the total percent body surface area that was burned. And they did this by just using burn specialists. And what they found is about 60 to 75% of the time they were accurate, which isn't that great if you're a specialist. But it's not because they can't count, it's often because the burns evolve over time. And so what maybe started off as, you know, a superficial burn is now evolving into a partial thickness burn, and now contributing. Additionally, studies show that a referring hospital does a very poor job at assessing burn size. We actually underestimate the burn size, but over resuscitate. One of the reasons they suspected that maybe we're not so great at that is those charts that we looked at, it's pretty standard. So it doesn't account for obesity. It doesn't account for people with like large breasts or redundant tissue. So what was proposed, but isn't really, to my knowledge, isn't really applied, is maybe using a fudge factor. And they talked about using the fudge factor based on like increase in like cup size for like women, but for morbid obesity, their concern is, are we underestimating in these patients? Another way that's like more fancy to assess the extent of your burn is doing like these laser Doppler analysis. They look at the velocity of blood cells. You can use this indocyanine dye. And again, these are more sophisticated for like burn centers, but generally look at skin perfusion. And then there's this thermography that looks at the temperature of the tissue and then the overall perfusion of it, which was really cool. So now that we have the extent of the injury, the burn depth down, now we got to talk about inhalation injury, because this is a big deal, especially for us in the ER and the ICU. And we'll kind of go through it. So there's different types of injury in your airway. So not everything is just like burned and singed and sloughing off. The upper airways do a really good job of being efficient heat exchangers. So the brunt of the thermal injury is all taken in by your upper airways. You get the reflexive laryngeal closure, and that kind of protects the lower structures. But in general, the heat itself denatures the protein and activates complement. And then this results in just increased permeability of the vasculature, leading to, you'll see edema, you'll see like swollen lips, swollen posterior oropharynx, you'll see singed nasal hairs, and hoarseness. These are all the consequences of the thermal injury. The tracheobronchial areas is largely due to chemical irritants. So it depends like what was being burned, like were you burning grass, were you burning oil or something like that. The Pathophyll Physiology, kind of just briefly, is really these irritants damage the respiratory epithelium. And this causes the increased vascular permeability and then this intense inflammatory response. Because of this, you get like these copious secretions. And this is because you get shedding of the goblet cells lining the mucosal epithelium. And then you can get these bronchial casts, and I'll show you a picture of them. But it's really due to kind of these inflammatory cells, the exfoliated epithelium that kind of clogs up your airways. In addition, you can also see just in general redness and swelling of the airway, just local like irritation. These are kind of pictures of what you'll see if you were to like do a bronchoscopy or cut in. But on, I guess your guys is right, is the obstructive cast, and these can develop anywhere from hours, like a couple hours, to up to a couple days after the initial burn. Also, we'll talk about how to treat that and what are proposed treatment modalities. Types of injury to the lung parenchyma itself is largely related to inhaled toxins. And when I say this, I don't mean like cyanide toxicity. It's not really fully understood why. What truly drives the parenchymal injury. However, it's been hypothesized that the bronchial blood delivers all this cytotoxic material and these cells into the pulmonary circulation. And normally these inflammatory cells can kind of like wiggle their way through the pulmonary capillaries, but they become like denatured and stiff and like clog it up. And so this causes damage to the lung parenchyma. You get VQ mismatching, and this is often delayed changes that you see in your vent. So you have a decreased PDAF ratio, your compliance goes down, you get pulmonary edema that forms. This is kind of a very complicated slide that kind of summarizes what I said, but essentially everything's interrelated, and playing in the bottom line is your lungs get hurt from being burned. So why do we care about inhalation injury? There was studies that looked at patients who had the exact same total body surface area that was burned. And when they accounted for comorbidities, what they found was that patients that had an inhalation injury had an increased risk of mortality compared to those with the exact same burn volume or burn surface area that did not have an inhalation injury. It's the leading cause of death in adult burn victims, so it's a big deal. These patients tend to have increased hemodynamic instability. So I kind of saw varying numbers, anywhere from 20 to 50%, but generally they require about 20 to 50% additional resuscitation above what a normal burn patient without inhalation injury would require. This is important because it leads to a lot of the consequences we'll see that happen with our fluid resuscitation. In addition, it causes just normal lung injury that we talked about, ARDS, multi-organ failure, impaired gas exchange. So how do we figure out who has an inhalation injury? We kind of talked about the signs you'll see as we go about, but this chart on your right shows kind of the signs you look for. So again, for the upper airways, the swelling of the face, you'll see hoarseness in the voice, singed hairs. As you get kind of further down, you might see hypoxemia, hypercapnia, depressed mentation, and then you'll see like soot in the airway. And if you're able to do bronchoscopic evaluation or fiber optic laryngoscopy, you can gain a little bit more information. When it comes to intubating these patients, using paralytics like succinylcholine is completely okay in the initial burn period up to about 72 hours. After that, just be mindful that the risk of hyperkalemia is profound. And so using something like rocuronium would be more beneficial in that. Okay, so managing these airways. Managing the airway in a patient who's not intubated. Supplemental oxygen is always like a great idea and the cornerstone. So you always want to gather as much information as possible for these patients. So, you know, get your AVGs, your chest x-ray, do that. If you're able to look at their airways and inspect them, please do that, because if you see any signs of hyperemia or their upper airways may not look so bad, but as you look further, you might see like epiglottic swelling, and as you give fluid resuscitation, that swelling might get worse. Always be mindful of a couple things. So carbon monoxide poisoning, and that your pulse ox is not going to be reliable. That's why even if the patient isn't hypoxic, you should always just slap some pulse ox on them, or supplemental oxygen on them, just to be safe. You should always obtain carboxyhemoglobin levels, and then even if your carboxyhemoglobin level is very elevated, above what was it, 20%, don't let that detract, and like the need for hyperbaric therapy detract from your initial resuscitation. So I'm like even just intubating the patient if their respiratory status is depressed, or if it's not, consider high flow to give them supplemental oxygen to try and wash it out. The other thing is be mindful of cyanide toxicity. So you should kind of always assume this in a patient who is involved in the fire that has kind of any kind of depressed mentation, a lactate that really can't be explained, and then a compensatory respiratory alkalosis. The treatment is always hydroxycobalamin, and this should always be given empirically in anybody that's involved in a fire that's coming in arresting and that's coming in with any altered mentation. Even if like they have alcohol or whatever on board, you should still be treating empirically. Other kind of adjuncts to the treatment. So bronchodilators, you can use them if the patient's like wheezing. There's no harm in doing that, but steroids should be avoided. What they looked at is patients with, I forgot if it was an observational study, but they looked at patients who received steroids, burn patients who received steroids versus not. And what they saw was increased risk of bacterial infection in the group that did receive the steroids. So it's actually recommended against to avoid steroids. Be mindful of your hydration and where you are in your resuscitation process, because as you're giving these large volumes of fluid, a very simple and direct airway may become an airway disaster just from edema from the tissues and the increased permeability that develops over time in that kind of initial phase. The other thing to be mindful of as we're treating these patients is just using lung protective strategies, which we're familiar with, but these eschars that may not be present initially may develop over hours in your ICU and now become so constrictive that you're getting high airway pressures that you can't ventilate your patient, and may necessitate escherotomy, which we'll talk about. Some alternative options that I kind of looked at that were being used is inhaled nitric oxide to help treat any hypoxic vasoconstriction. And then this one I thought was so cool was it was aerosolized heparin and NAC. And this is to kind of remove those casts that I showed, that like white gunky stuff. It was a single center, small, non-randomized controlled trial in pediatric patients. And these patients all had inhalation injury that was confirmed on bronchoscopy. What they found is the patients that were treated with the aerosolized heparin and the NAC had decreased reintubation rates, atelectasis, and a decreased mortality. Now, it was a single study and there needs to be more studies, but I thought it was really interesting. Why it works, I have no idea. All right, so now the meat of our presentation is how to resuscitate these patients, right? It's such a tricky, delicate balance, and we often are find ourselves landing on one extreme or the other. So in terms of resuscitation, so there's something that's kind of referred to as burn shock. Essentially, it's just a hypovolemic shock. But generally, you're seeing this in patients who have upwards of 15% total body surface area that's burned. And remember, greater than 10% TBSA, we're transferring out. So it's really important to balance our resuscitation of the patient with also the consequences of our resuscitation. So rather there's studies that show increased mortality when you're at either extreme of your resuscitation. So if you're under resuscitated, you have increased organ dysfunction, organ malperfusion. When you're over resuscitated, your risk of ARDS, your risk of compartment syndrome, and airway complications increases. The goal of your resuscitative process should be just this: counteract your volume lost by replacing it. It's nothing more complicated than that. And we'll kind of talk about the Parkland formula and kind of the caveats of it because it's not an end all be all. You need to frequently monitor your response to your resuscitation and don't be afraid to alter your resuscitative efforts based on the patient's response. So we'll talk about what our endpoints are and how we kind of titrate our fluid based on that. So the most important thing that I hope everybody takes away from this is that the Parkland formula is a starting point. It is not a blanket thing that is applied to every single patient. That gives you a rough idea of what you should give the patient. However, you have to monitor their response to the treatment, because if you're making their urine 2 cc's per kg per hour, you're over resuscitating the patient and you're increasing their mortality by doing so. So scaling back and seeing what that patient needs and what to match like their physiologic state right now is the most important. So LR is preferred given just the high volumes that these patients require and the risk of, hyperchloremic acidosis. And there were studies that looked at using colloids alone. And when they looked at that, there was no really difference in mortality, just as you could expect, a decrease in the volume infused, which maybe begs the question then, could this be more beneficial if we're seeing all these complications from our resuscitation? They describe something called fluid creep. And what that essentially refers to is because we have these increased permeability of our vasculature, we kind of get all this, anasarca, this edema in our airways, the edema within our tissues that leads to compartment syndrome, ischemia of our fingers, and decreased perfusion. So the question is, considering adding colloid in addition to cut back on the volume when we're using crystalloid. And there's no great study that's looked at this like a non-randomized control trial, but one of the studies I looked at mentioned that there's a potential benefit if you add colloid at about the 8 to 12 hour mark, if you're starting to see signs of, increasing edema and not meeting your endpoint. Just being mindful that inhalation injury does often require additional resuscitation too. And then you always have to adjust your fluid in response to the patient's in response to what the patient is requiring. So fluid resuscitation, what are our endpoints? So really we should target at least 0.5 cc's per kg per hour. And this is unique to thermal injury. Electrical injury should be about 1 cc per kg per hour. And again, this is for adults, not peds. Mostly because this is just a surrogate marker of, you know, your GFR and your cardiac output, but it's really important to remember that this is a single marker. So in an ESRD patient that comes in, and a DKA patient that comes in with polyuria, and someone who's drinking or taking diuretics, you can't really trust it entirely. It's just one point on the spectrum. It's really important to consider other endpoints of your resuscitation using your heart rate, your blood pressure. You can use echo, your CVP monitoring. And these patients, burn patients, tend to be in this hypermetabolic state, which we're going to kind of discuss. So it's not uncommon that even an adequately resuscitated patient still is tachycardic. Generally about 110 to 130s is what's been documented as about normal for an adequately resuscitated adult burn patient. And then also monitor your normal end markers of organ function. This chart here is something that's used by the military in combat for patients that come in with burns. And it literally goes like frequent reassessments of your heart rate, your output, your blood pressure, everything, to then titrate your fluid based on that. We're going to kind of wrap up the presentation with kind of our post-burn care. So what do we do now that the patient's resuscitated, and how do we deal with the consequences of it? So as we talked about, always make sure you're removing the burned jewelry, clothing of these patients. But minimizing the burn zone is important. And this is particularly important in patients with superficial partial thickness burns. Using copious irrigation to cool the area can actually minimize the extent of the burn, as well as it has been shown to actually decrease the overall pain that the patient feels, like long-term, even outside of that cooling period. You can use like a saline soaked gauze, but it's recommended not to keep it on for longer than 30 minutes. And then if you're able to apply like any kind of topical antibiotic to the area and then wrap it with like a Vaseline gauze or something, that is the best. For the deep and full thickness burns with the eschar, just using a dry gauze and then transporting the patient is sufficient. I mean, you can apply a topical antibiotic, but it's not going to stick to the skin or be absorbed. As the total body surface area increases, your risk of hypothermia also increases as well. So just being mindful of these patients and maybe consider using warmed IV fluids. When it comes to their blisters, if it's intact, let it be. Don't touch it, don't pop it, don't do anything. If it's ruptured, you can go ahead and debride the area if you're not transferring the patient. Otherwise, you can just leave everything as is and then transfer the patient. So escherotomies. So I hope we never ever have to do this, but basically these become really, really stiff and constrict and cause changes in perfusion, ventilation of the structures, depending on where you have your eschar at. Ideally, this is performed by a burn specialist, but it is indicated and should be performed even by an untrained person if there's any signs of poor perfusion or impaired ventilation. Looking for perfusion can be difficult in a patient who's burned skin. You're not gonna like necessarily see your capillary refill the best, right? But using Doppler signals is important, feeling the temperature of the skin and being mindful of that. Also, when it comes to ventilation, you know, if you're having high airway pressures, you can't ventilate the patient, you may need to do an escherotomy. I have pictures kind of on the screen of kind of common areas. The hands, you generally make the lateral cuts. And then on the chest, you kind of just make an outline of where you would expect your lungs to kind of be. When you're doing this, if you're inexperienced, do not worry about your cosmetic concerns at all, because all of this is going to be grafted over. So there's no concern whatsoever about worrying about this. The patient has bigger issues at that point. In general, the incision should just cut down to the adipose. However, if there's signs of like abdominal compartment syndrome, your pressures are high, then you're going to have to extend your cut, hopefully at that point with a surgeon present, down to the fascia. And in general, the swelling that you'll start to see and the rise in pressures, it's often not immediately when the patient presents. It's often several hours into their resuscitation and even a couple up to 2 days within their initial arrival. This is just a picture of somebody who required every single cut. So this hypermetabolic state, I found this super interesting because in the ICU, we care for patients all the time that, you know, in their critical illness, they have, you know, this hypermetabolic state. But what was interesting is how profound it is in a burn patient and how long lasting. So about more than, if you have more than 20% total body surface area burned, in general, you have an increased metabolic rate by 118 to 210 times that of normal. And that can be maintained up to a year out, even if your wounds are closed and everything. There's 2 phases, and I have a picture on the next slide that'll kind of show you, but initially in your ebb phase, you're extremely vasoplegic. You don't have that hypermetabolic area. And then in that flow phase, that generally increases over the first day to about 5 days. That is where you become this like hypermetabolic state. That can last up to 12 months in patients, and even like the effects of glucose metabolism impairment can even persist up to years past the actual inciting injury. This is an example of kind of the differences with our normal critical illness patient versus a burn victim. So you see in the orange that initially you have your injury, whatever sepsis it is or trauma, and you have this like decreased metabolic rate, right? And that initially just occurs within like the first day or so, or day or 2 of the injury. And then all of a sudden you become hypermetabolic and you peak and you come back down to baseline. With the burn patient, you have that same initially, but then you have this increased, this hypermetabolic area that stays increased for months to years, even after the injury itself, before eventually returning back to baseline. I'm going to kind of briefly touch on this because the next slide summarizes all of it, but how do we treat it? Really, studies have looked at these things. So early excision and grafting has improved outcomes, using anabolic steroids to help improve your nutritional status and the catabolic effects from your increased like energy expenditure, using beta blockers, early nutritional support, and then addressing your pain and anxiety. One study that looked at early excisional grafting, and what they defined this within the first 5 days. So that was like early versus late was like 10 to 14 days, was associated with a significant decrease in mortality in these patients, decreased hospital length of stay, which was huge. In addition, the steroids also shortened the hospital length of stay. There was no mortality benefit, but did show increased successful donor healing, as in the site that you were, this tissue was taken from, and then a reduction in the overall weight loss of the patient. A beta blocker didn't really show any mortality benefit, but is commonly used for this hypermetabolic state just to prevent like long-term consequences of a tachyarrhythmia. And then early nutrition decreased both morbidity and mortality, as well as the risk of sepsis and bacterial translocation, which I thought was pretty impressive, considering we don't often consider nutrition as in the forefront of our, resuscitation and care. Interestingly, pain management and anxiety management was associated with delayed healing and worse outcomes as well. These patients require often exorbitant amounts of pain medication. So what is recommended is that we target like this, what they refer to as a background pain. And you can do this by using like a PCA or methadone, some sort of long-acting opioid to help kind of prevent like just the ups and downs in our management, as well as then providing additional pain medicine that goes with wound care, and for obvious reasons, avoiding IM injections. When it comes to anxiety, patients have long-lasting anxiety from their burns for, I mean, their face is deformed. They have just anxiety revolving around wound care, which can last weeks to months, even after the initial burn. So being mindful of that, and poorly controlled anxiety was shown to have an increased perception of pain and increased opioid requirements. So even managing this aggressively did have implications for your pain management. And then often down the road, you might see these patients and they have tons of itching from their grafts as they start to heal. And there's a number of topical creams you can use. Where do these patients go? So there is a significant increased mortality with inhalation injury, and then as your total body surface area burned increases. The mortality is anywhere from 3 to 55%, which is a really wide range. But again, it depends on a variety of reasons. You know, your resources, are you a burn center? Is there a delay in transfer? All of this plays a significant role. Was this a mass casualty event? And then the early mortality, which was defined as less than 10 days, was highly associated with patients who were under resuscitated. So while I scared you guys hopefully into not over resuscitating patients, under resuscitating patients too is extremely detrimental. In general, what can be expected is for every 1% total body surface area burned, you should expect about 1 day length of stay in the ICU. So 80%, 80 days roughly. And that's just in the ICU alone. After that, patients often require several weeks on the floors dealing with the contractures, their functional disabilities, complications from the grafts, and nutritional issues. Take-home points from this presentation. So I hope that you guys remember that with burns, we have to frequently reassess them over time because they evolve, they get worse, and we have very much care in handling the burn patient, their clothing, and taking care of ourselves in that moment. If there's any concern about the airway, just secure it. You're never wrong to secure the airway early in a burn patient, and be mindful that, you know, your injuries are likely going to get worse as your resuscitation goes on. Also, that the Parkland Formula is not an end-all be-all. It is a starting point. It is something to help guide our resuscitation, but ultimately it is an art, and we have to be very mindful of how our patient is responding to this, whether they need additional fluids or less fluids, but just making sure we're not landing on either extreme of our resuscitative efforts. Know that inhalation injuries require more volume often, and then just aggressively treat pain and anxiety because they have significant long-term consequences. Any resources? Any questions? Good.